Good afternoon. So I will be presenting on these indicators and some of the approaches CDC is pursuing to improve on these indicators. First, a disclaimer that this presentation does not necessarily represent the official position of the CDC. So the national strategy for the United States released in 2010 already included an objective to increase to 90% the people who know their serostatus as part of the goal to reduce infections. Other goals were to improve care and health outcomes among people living with HIV and reduce HIV-related disparities. So CDC and its partners have pursued a high-impact prevention approach that includes increased testing, prevention with positives, which includes improving care and viral suppression, evidence-based interventions for high-risk populations with a focus on communities at high risk for HIV. So what does 90-90-90 mean for the United States? On the right-hand is a picture of our continuum of care. So from a relatively high cliff of diagnosed, we have a steep drop to retention in care. While for those who are in care, the majority have a suppressed viral load. So we need to continue our testing efforts. We also need to focus on improving retention in care and viral suppression. So our indicators are based on the National HIV Surveillance System. All states and US-dependent areas have surveillance in place that allows us to track patients over time. We use a back calculation methodology using this data to determine total prevalence as well as the percentage undiagnosed. And we use the reporting of CD4 and viral load test results to look at entry to care, retention in care, and viral suppression. So we estimate for the 1.2 million people living with HIV in the United States that about 87% know their serostatus. These are data for 2012. And we do see differences by race ethnicity. So blacks and Hispanics have a lower percentage diagnosed than whites. For whites, we estimate that they reached the 90% goal. And they are the ones that have the highest diagnosed from all race ethnicities. MSM comprises the largest risk population in the United States, and we estimate about 85% know their serostatus. But the biggest disparity is by age, and so as age increases, the percentage diagnosed increases. We have a full reporting of all CD4 and viral load test results for 28 jurisdictions for 2012. That's about 61% of the population living with HIV, with diagnosed HIV. And we look at care as having had at least one CD4 viral load test result in a given observation year, and retention in care having 2 or more test results at least 3 months apart. So for 2012, we find that about 68% of people with diagnosed HIV were in care, and 54% were retained in care or had 2 test results in that year. We see some differences by race ethnicity and by age. Viral suppression is based on a viral load less than 200 copies per ml, the latest test result that we have for the observation year. And again, in these 28 jurisdictions, among people with diagnosed HIV, we find that 50% had a suppressed viral load. We see marked differences for blacks and Hispanics compared with whites, and we see, again, marked differences by age. Now, in 2012, the treatment guidelines were just released that recommend universal offering of treatment, so we don't yet quite have the data to see what the uptake is after 2012. So how do we translate data into action? Our first step is to make sure that our funding is allocated according to the distribution of the disease. So on the left map, that is a distribution of the people living with diagnosed HIV, and on the right side shows the allocation of funding for the core prevention funds that CDC gives to state health departments. So we are in the process of making sure that all of our programs are allocated correctly. For actual interventions and to make sure that we to where the action needs to be, that is at the local level. We encourage local and state health departments to construct their own continua of care. We have just for the first time released data on the percentage with diagnosed HIV on the jurisdiction level, and we can see here that 5 jurisdictions are at or above the 90% standard, and there's still a wide variety of or variability in the percentage diagnosed. For HIV testing, the testing guidelines that CDC has put out, we recommend that there's routine opt-out testing in healthcare settings, and that is what the core prevention programs pursue that the health departments are implementing. They are also doing targeted testing in non-healthcare settings to reach individuals with undiagnosed infection. And some areas are funded for an expanded HIV testing initiative that focuses on disproportionately affected populations such as African Americans, Hispanics, MSM, or people who inject drugs. We have limited data to track testing rates, so here are data from our National HIV Behavioral Surveillance System. We see that testing within the past year among MSM increased from 63% in 2008 to 67% in 2011. A sub-analysis also showed that recent testing increased in the cities that were funded for an expanded testing initiative and not in others, and the biggest increase was for Black MSM. Now, to improve the other steps in the continuum care, the CDC and its partners are pursuing what we call the data to care approach. So we use surveillance data or a linkage of surveillance data with provider data to identify persons out of care or who have a high viral load. And those are listed for follow-up. And there are different models on how to follow up. In the health department model, the health department partner services or case management staff follow up with the patients to reach out and re-engage them in care. In the healthcare provider model, the healthcare provider initiates the linkage and re-engagement, and then some health departments use a combination approach. What we don't have is evidence-based data to tell us what works best when health departments try to pursue this approach. And to this end, CDC is funding the cooperative re-engagement controlled trial. The study aims are to determine the extent to which a health department intervention can engage out-of-care persons in medical care, to describe the health department clinic collaboration to identify out-of-care persons, and to measure cost effectiveness. And the methods are the data to care approach that I just described. So this is a 5-year project, and this is just year 1, so we're working on the protocols at this point. So before I close, I just want to touch on some other activities that CDC is conducting, such as program guidance and training, technical assistance for evidence-based interventions. And some of those include medication adherence or linkage to and retention in care. And then we also have extensive communication campaigns under the umbrella of Act Against AIDS. Some of those campaigns are about testing, so testing geared to Black MSM or Hispanic MSM, to providers to make the screening and linkage to care standard of care, and also geared to people living with HIV so that they stay in care. So in summary, we need to improve across the continuum of care. We need to make sure that the targets are met for MSM, African Americans, Hispanics, or Latinos in youth so that we can address the disparities. And we need to continue to maximize the data used on the local level so that we can drive the appropriate action and evaluation of our interventions. And I want to acknowledge our state and local health departments who provide the data and conduct the programs, and as well as my colleagues at the CDC. Thank you.